Hello, I'm Michelle Batty and welcome to the EUROGEN webinar series. Just before we get started, I'd like to take a couple of minutes to explain about what an ERN is and does. 24 ERNs were created by the European Commission in 2017, and they're all aimed at helping patients with rare diseases and complex conditions that need highly specialised surgery. EUROGEN, one of the 24, aims at dealing with patients with rare urorectogenital diseases and complex conditions. So, all areas where highly specialised surgery is needed. We are currently a network of 56 healthcare providers in 20 member states. And some of the activities we do together, along with educational activities like this webinar series, is we use a new tool given to all the ERNs by the European Commission called the Clinical Patient Management System. This enables us to have safe, secure, cross-border virtual consultations on patients with rare diseases. So we can give advice from a number of different experts across the network in different countries who all have experience of treating numbers of these patients before. And of course, that's part of the problem. Each country alone normally has very small numbers of patients. So we would be delighted to receive requests from anyone out there who would like to use CPMS with us. It's very easy. Darren can get you onto the system in less than half an hour. And as I say, this service is free to any healthcare professional working in the EU. So please feel free to reach out. We love using the new system and we'd be delighted to help more clinicians out there. We also have a EUROGEN registry, and that's really exciting because it means that we can pull together fragmented data from across the whole of Europe, and that's really important for our patients with rare diseases. Please get in touch with us if you'd like to join our registry. It's open to any hospital, again in the EU, also outside the network. So we're also at the EAU this weekend, so please feel free to come and have a chat with us about anything, any of our activities. We're in the Patient Plaza, so do come and find us, and also do come and join our scientific session on rare and complex urology on Sunday. So, this evening, well, we've got a really interesting topic. It's robotic surgery in functional and reconstructive urology, shaping tomorrow's standard. And it's an absolute honour and a pleasure to welcome here tonight's speakers, who are Dr. Tim Brits, and he's from Antwerp University Hospital, and also Dr. Donald Vaganée, and he's from Clinique Saint-Jean, Brussels, Clinique Universitaire Saint-Luc, Brussels. And thank you very much to both our speakers, and we're really looking forward to hearing your view today. I will hand over the floor now to Tim. Thank you very much for being here.
Good evening, everyone, and welcome this evening for this webinar. And thank you to the ERN for this opportunity to host the webinar. Donald Vaganée and myself will talk you through robotic surgery in functional and reconstructive urology to see if we are really shaping tomorrow's standard, or if it's just a case of having a new hammer so everything looks like a nail. We have nothing to disclose. Looking at the evolution of surgery, it all started off, as we know, with laparotomy, moving towards laparoscopy, and finally we went to robotic surgery in the early 2000s. From laparotomy to laparoscopy, we see smaller incisions with less hernia, less wound infections, less wound problems. With the addition of a camera and a magnified camera view, we have better visualization, especially in limited movement areas. There's also reduced blood loss and a shorter hospital stay in general. Moving on to robotic surgery, you have further enhancement of your visualization due to a 3D high-definition vision and a stable non-tremor camera control, which you control yourself as a surgeon. You have also improved instrument control with tremor filter, endo-wrist articulation, so you get your wrists back as a surgeon, and also even in your platforms you have the option of tactile feedback. With all these enhancements, and especially with single port robotic systems, we see a new variety of access and approaches. So we already had the transperitoneal approach. Even retroperitoneal was possible with multi-port system, but now natural orifice surgery is fastly gaining in the robotic era. It's fastly gaining traction, especially transvaginal approaches to the retroperitoneum or to the abdominal cavity. There are also a lot of technological advantages and training advantages, which we will discuss in the end of the presentation. So moving from laparoscopy to robotics, as I said, surgeons are regaining their wrists back. So we can maybe conclude that you wouldn't accept a surgeon with bilateral wrist immobilization to operate. So maybe robotics is the logical step forward, moving away from laparoscopy. So to guide you to the presentation today, we have two major speaking points, which are surgery in narrow spaces, in which we believe that robotic surgery can be very helpful, and technically demanding procedures with a lot of intercorporeal suturing and dissection. We divide them further into female pelvic reconstruction, continence surgery, and bladder outlet reconstruction as the narrow space surgery, let's say, and then bladder reconstruction and upper urinary tract reconstruction as the technically demanding procedures. So to start off with the female pelvic reconstruction, one immediately thinks about sacrocolpopexy, which is the golden standard for level 1 apical vaginal prolapse. I hear a lot of surgeons emphasizing the difficulty of doing this procedure laparoscopically. Compared with robotics, this is one of the easiest procedures. This is a procedure which is taught to residents or junior surgeons as one of the first procedures performed. So we move from a very difficult procedure to a very doable procedure. Outcome-wise, when looking at the literature, we see cure rates of 80 to 100%, which is comparable to open or laparoscopy. We have a lower conversion rate, only slightly lower, but lower conversion rate compared to a laparoscopic approach. It's day case surgery. Also in an era where surgeons have to operate until their late 60s, improved ergonomics might be important, especially when treating multiple cases in one day, which can definitely be the case in sacrocolpopexy. And then easily performed concomitant procedures can be an added benefit. I think about vertical suspension for incontinence can easily be added to a sacrocolpopexy. When taking difficulty a step further, I would like to talk about vesicovaginal fistula repair, where robotic surgery can be of added benefit. Of course, we agree that a transvaginal approach is feasible or maybe even preferable for obstetric fistula or less complex vesicovaginal fistula. But in more complicated cases, thinking about large fistula, multiple fistula, as the image on the right is showing you, previous surgery, irradiated patients, involvement of the UOs can be a reason to opt for robotic surgery. The robot can be interesting deep in the pelvis for the vesicovaginal fistula repair. You can easily dissect the bladder and the vagina. You can go transvesical, or you can stay outside the bladder. You can check vascularization with ICG, with Firefly, and have a tension-free closure with easy interpositions. In literature, outcome and success rates are high, reaching to almost complete success and complete treatment of the fistula. And then maybe the most challenging surgery in female pelvic reconstruction are mesh and mesh complications. So we are still using a lot of mesh outside few countries. We're still using a lot of mesh for stress urinary incontinence and even for prolapse repair. Of course, as we all know, there are potential complications which can seriously harm patients and which are very difficult to manage. So I think we have to look at the least invasive management for the patients with the highest success of mesh removal or near complete mesh removal. And I think robotic surgery can definitely help us in these types of surgery. Of course, as you see on the screen, other options, endoscopic, transvaginal, open laparoscopy are all possible treatments for mesh complications. But I think robotic surgery has limited invasiveness and succeeds in high rates of mesh removal. This is also being published by Eva Fong and her colleagues in about 20 patients. They published their early experience of removal vaginally placed prolapse mesh. They have a transabdominal approach, but also they're pushing the boundaries of robotic surgery by using a transvaginal approach to remove the mesh or even combined vaginal and abdominal. In their series, although rather limited numbers, but in their series, they see a mesh removal rate or a near complete removal rate of 83%, which is quite high. In this short clip, I will mute the volume, I'm sorry. In this short clip, you can see a robotic removal of two sacrocolpopexy meshes, which were eroded in the anterior as well as the posterior vaginal wall and in the bladder detrusor, which could quite easily be removed robotically due to a high level of dexterity you have with robotic surgery and also with improved visualization due to the robotic platform. So I think it's a good option to treat mesh complications with robotic surgery. I will now move over to Donald to discuss another topic in continence surgery.
All right, thank you. So Tim has already done a great job illustrating the role of robotic surgery in functional urology, and I have now the pleasure of discussing one of the most compelling indications for the robot in this field, namely robot-assisted bladder neck artificial urinary sphincter implantation, and we will start with the woman. So to achieve urinary continence in women, two elements are essential. You need to have full ureteral support, and you need to have a good function of the internal and the external ureteral sphincter. Artificial urinary sphincter is mainly done for patients with intrinsic sphincter deficiency, and we often see those who already had anti-incontinence surgery, who had pelvic floor surgery, who were irradiated, and of course a neurogenic sphincter incompetence. And their artificial urinary sphincter is the only procedure which can restore the storage function, but also the voiding function. And typically these patients on urodynamic investigation show a very low Valsalva leak point pressure, usually before under 60 centimeters of water, and a maximal ureteral closure pressure that's lower than approximately 20 centimeters of water. Clinically, it means that they're leaking urine all the time. Compared with the male AOS implantation through a perineal approach, the bladder neck AOS placement in women is technically more demanding, So in men, the bulbal urethra is easily accessible to place the cuff, while in women, it's almost not feasible to go perineal, so you have to go transabdominally, where it can be a little bit more difficult to have a nice dissection plane. So the main challenge in females is the dissection of the vesicovaginal space between the anterior vaginal wall and the bladder neck. And in this step in particular, the advantage of minimal invasive surgery are particularly helpful. The improved visualization, the pneumoperitoneum, that you also have with laparoscopy, but the robot adds, of course, the articulated endowrist instruments, allowing you to have a really precise dissection. This is a multi-center comparative study of several centers in France. And quite interestingly, they evaluated open versus robotic assisted AOS implantation. And you can see why it's being considered as a very technical and demanding procedure, because with the open approach, complication rates are as high as 27, are very high, with more than 27% explantations within 2 years after the operation. When we look at the results of the robot-assisted implantation, we see fewer complications and also much better functional outcomes. Also, if you look well, the explantation rates is nearly 25-fold lower. Then the group of ERN compared robot-assisted female AOS implantation with perineal male AOS implantation, which is also quite interesting. And what they saw was that the explantation and revision rates were comparable, while functional outcomes were significantly better in the female AOS group, which confirms that robot-assisted AOS implantation in women is both safe and very efficacious. When reading or hearing about artificial urinary sphincter placement, there are two main surgical approaches that are commonly described: the anterior approach and the posterior approach. For those who are not familiar with it, I will try to explain it. So with the anterior approach, you will do the dissection between the bladder neck and the anterior vaginal wall through an anterior approach. So you will enter the space of Retzius, whereafter you will do the dissection from anterior to posterior. Online, there are lots of great videos of it, but this is an image of the most important part during the operation, which is creating the tunnel between the anterior bladder wall and the bladder neck. So here, space of Retzius is already entered. This white shiny tissue, also known as the bald plane, is the anterior vaginal wall that's already dissected. And here you can see the right instrument pulling away the bladder neck in order to protect it. And with the left instrument from left to right, the tunnel will be made, after which the measuring tape can be placed, and afterwards the cuff. With the posterior approach, you start posteriorly, actually exactly the same as you would do with a sacrocolpopexy, but then you go a little bit lower until you reach the bladder neck, which you know if you see the balloon of the catheter at that location. And then you will go from posterior to anterolateral for the dissection of the bladder neck. Here you can see it in a video where you can see here the anterior vaginal wall, and here you can see the bladder neck. Then lateral, a tunnel will be made, and when you see the fatty tissue, that's usually a good sign. It means that you're paravaginal. Then the instrument will be brought from posterior to anterolateral. Yeah, exactly. And then we can give the measuring tape here from right to posterior side. And then exactly the same will be done on the left side, after which you can place the measuring tape, measure the adequate size for the cuff, and cuff placement. So yeah, there's limited data that have compared the anterior with the posterior approach, and definitely no head-to-head comparison. There's a French study and a Chinese meta-analysis, and yeah, I think we can conclude that both methods appear to have same perioperative outcomes as well as functional outcomes. Then I will briefly discuss the use of a bladder neck artificial urinary sphincter in males. The indication, surgical techniques, and outcomes are largely similar to those in females. The main indication is a neurogenic sphincter insufficiency, partly in patients with conditions such as spina bifida and spinal cord injury. In a study from Pieter-Salpêtrière, an open approach was compared with laparoscopic with a robot-assisted approach, and the robot-assisted approach was associated with fewer peri- and postoperative complications. However, functional outcomes were similar between the two techniques. So most is comparable with what has been observed in female AOS implantation, except for that there was no difference in functional outcome, whereas in female AOS placement, there's also a large difference in functional outcome. Yes.
Okay, then it's back up to me. I think we cannot talk about surgery in a small, in a limited space without talking about male bladder neck surgery in bladder neck contracture, either after radical prostatectomy for prostate cancer or after benign prostatic obstruction surgery, where bladder neck contraction in both types of surgery can be an issue. Standard, a transperineal open approach was used to treat the bladder neck contractures. The main problem in that type of surgery is a high number of de novo incontinence. So after a perineal approach, almost all patients develop de novo incontinence, which can seriously hinder their quality of life. So the benefit of robotic surgery is that you can treat a bladder neck contracture either transabdominally because of your improved dexterity and better visualization due to image quality and image magnification. So transabdominally or transvesically with YV-plasty or with buccal mucosa, you can treat these contractures. When looking at literature, the patency rate, either robotically through a YV-plasty or open transperineal, the patency rate is the same, around 8%, but robotically, the de novo incontinence is much less. Seeing this in practice, in this video, a YV-plasty is performed. First of all, opening the bladder through vertical cystotomy, and then secondly, the incision of the contracture of the bladder neck. After incision of that bladder neck, which you will see in a few seconds, hopefully. So you can see the guide wire passing through the stricture, and the rim of the stricture, in this case a quite short stricture, is seen. So after stricture incision, the two limbs of the Y are created. And then to end off, the point between the two limbs of the Y is sutured downwards, creating a V shape. And after suturing, the contracture should be or is hopefully treated. Okay, and then moving away from surgery in deep in the pelvis in small location, we can go to reconstructive surgery with difficult suturing work or difficult dissection. When talking about suturing, I think there aren't many surgeries which require as much suturing as a bladder augmentation, for which robotic surgery is feasible. Studies have been done again in France, where they see that robot-assisted surgery has similar functional outcomes to open bladder augmentation, but with fewer or with a very low amount of complications in the neurogenic patients as well as in the non-neurogenic, typically bladder pain patients. Especially deep down in the pelvis, when suturing the bowel segment to the bladder, especially at that moment, the robotic platform can be useful in making a nice watertight suture between the bladder and the bowel segment, as you can see in the short clip on your right side. We can discuss if you can call a cystectomy a reconstructive bladder surgery, but nevertheless, a lot of complex cases tend to end up with a cystectomy and ileal conduit. This has been extensively researched and published by our oncology colleagues, but the group in ERN also published their data on cystectomy in functional patients, looking at their open cystectomies, laparoscopy, and robotic cystectomies. So they see that the benefit of the robotic platform lies in the fact that there are fewer major complications compared to open surgery and also compared to laparoscopy. Especially in suturing of the ureters to the ileal conduit. Robotic surgery can be very interesting in making, again, a watertight suture with a small suture. Ease of suturing, maybe even speed of suturing, is higher using the robotic platform. And to end things for me, after which Donald will finish the presentation, we have to talk about the formation of a continent channel for catheterization, which is a challenging procedure robotically, especially when combined with an enterocystoplasty, but is definitely doable. Again, a French group from Nantes published their data only on 12 patients with different types of channels, so Monti channels, spiral Monti channels, and Mitrofanoff channels, which were tunneled to the bladder using robotic surgery. They saw excellent outcomes, so a high patency rate, a high CIC success rate, and all channels were continent with a complication rate or Clavin-Lindo 3 and up complication rate of 17%. So even for those challenging cases, robotic surgery might be feasible, but we only see at this time a limited amount of evidence, but we're hopefully getting there.
All right, thank you. I'll try to speak a little bit slower because I see we're even ahead schedule. But another very interesting topic as the upper urinary tract reconstruction. It's another field that is rapidly evolving and expanding, I think, thanks to the advantage of the robot-assisted approach. The main advantages are, of course, precise dissection and a fast and accurate suturing. There are several studies that have shown shorter operative times, and that's even when including trocar placement and docking for procedures such as distal ureteral reimplantation, as well as spiloplasty. And on the left, you can see the EAU 2025 guidelines for the management of ureteral strictures. And in the middle, it's a recent review article that summarizes the different techniques available for UUT recon. And you can see that, particularly for distal ureteral strictures, there has been a clear expansion as well as a diversification of techniques in the recent years. And for pyeloplasty, here you can see again 2 studies demonstrating a decreased operative time when using the robotic approach compared to laparoscopy. But honestly, I believe that the greatest advantage of a robot-assisted approach here is its versatility in upper urinary tract recon, particularly for mid-ureteral strictures, but it's actually for all. You never know exactly what you will encounter intraoperatively, and having a broad armamentarium of reconstructive techniques, as you just saw, allows you to adapt to every situation and achieve the best possible surgical outcome. And these are 2 techniques that are used with increasing frequency, I think. And it's use of either a mucosal graft only, or of the use of the appendix. So when you have a ureteral stricture, the ideal indication is if it's a long segment, meaning often more than 2 centimeters. If it's quite narrow, you can just incise it and do an onlay with mucosal graft, either bladder or buccal, or the appendix. When you have the same segment, but it's nearly obliterated, then you have to cut it out. You do a ureterostomy, and you do an augment with the mucosal graft or even the appendix. Here you can see a beautiful example of a long mid-ureteral stricture repair using a bladder mucosal graft by a colleague of mine from Saint-Luc. There's a patient who previously underwent radical prostatectomy with adjuvant radiotherapy for prostate cancer, and the ureteral stricture occurred after ureterorhinoscopy for kidney stones. So here you can see the dissection of the ureter. So you can see the tissue is extremely adherent. This is further mobilization and take away all of the scar tissue. Then the stenosis is measured in length. It's about 4 centimeters. Then the tension is taken to the bladder, which is being filled. All the fat is being removed in the detrusor, and then very carefully the mucosa will be dissected. And we measure the length and the width. Then the ureter is opened. The tissue looks quite fibrotic, but it bleeds well. In this case, double G stent was in situ. You could also do ureteral rest beforehand. Definitely, if you have small stricture or a stricture that's bothering, but it's not extreme. So it's better to visualize if there's no stent inside afterwards, to better delineate the stricture length. Then the bladder graft is harvested. Bladder closed in multiple layers. Then the bladder graft is sutured. If there's doubt about the vascularization, you can use indocyanate green, Firefly. Well, and afterwards you can do an interposition with omentum or peritoneal flap. So we already said a little bit about Firefly or indocyanate green, which is extremely helpful. So it's an intravenous fluorescent dye that binds to the plasma proteins, and when illuminated by a near infrared light, it will become fluorescent, and that way we can image the vascularization and detect also if there's an ischemic segment. For example, this is a ureter, which seems okay, but when we use indocyanate green, we actually see that all the distal part is a vascular, and so we need to excise it all to have a good anastomosis. And then we will say something short about the educational value of the robot platforms. First of all, it's been shown that it's a shorter initial learning curve, and you also have enhanced teaching opportunities. So, which is great, is that you can use surgical videos and structured video reviews, so you can see all the videos of yourself that you've done all the cases, also of your colleagues, if you, often it's available in the center. But also, I think if you look on the internet or online, for example, if you want to see a radical cystectomy with intracorporeal derivation, I think you can find 5 videos, full-length narrative about some of the biggest names in urology. You should try the same for open surgery, to find a full-length video of an open surgery that was recorded well. Yeah, I don't think you will find it that easily. So it's just way more easier to look all the videos and how people are doing different approaches. All the training platforms are also very good and increasing in quality. You can even do a simulation of a full prostatectomy, which is also extremely helpful. The dual console is also a big advantage. The fact that you can just hand over your controls without moving, and the fact that someone can just write on a screen where to dissect, it's also extremely valuable. Proctor is always important, but these days you can even do external proctoring, so people can see what you're doing from a long distance and can advise you what to do. And probably in the future, they will even be able to take over the instruments, as we already saw that you can do an operation from miles away, figure of speech. So that will be an advantage. And we will also perhaps have assistance of artificial intelligence, as in late February, was a surgeon, a Belgian surgeon, who performed a procedure with AI assistance. So these are all, I think, very valuable things for the future generation. So to conclude a little bit, robotic surgery expands surgical possibilities in functional and reconstructive urology. It's particularly advantageous in confined anatomical spaces requiring precise suturing. Of course, the indication and surgeon experience remain key. But most importantly, we hope we've shown that the future of functional and reconstructive urology is incredibly promising, and that robotic surgery will be one of the key tools helping us shape it. Thank you.
Thank you.
Thank you so much. We can go over to the discussion section of the webinar. Let me see. So as I mentioned before at the very beginning, you can find the Q&A section down below your screen. There's an icon with a question mark on it. That is where you can type in your questions if you have any. So I will let people have the chance to write some questions. You can also raise your hand and I can try to unmute you if you would like to ask the question verbally, so we will have a more dynamic discussion. So yeah, I would like to thank the presenters. I always find it very fascinating how the technology is evolving and what we can do these days with these robotic surgeries. The technical videos were very nice to watch. I will have my usual announcements right now, so I give people more a chance to write their questions. I can see that somebody has already a question, but the webinar has been recorded. So just so you know, I will be sending the link to the recording tomorrow, so you can always watch it back and watch back the slides as well. So yeah, we have a question by Michel Wijndalen. Perhaps you can read the question out loud so everyone knows what's being asked and then answer it.
Yeah, sure. Thank you. And thank you, Michel, for the question. The difficult question Michel is asking is in the perspective of functional reconstructive urology, in which way we would like the robotic systems to be developed further. I think the development which is happening now is interesting. I mean, the single port systems giving you access to surgical options we didn't have before, or surgical cavities we didn't operate through before. So I think transvaginal surgery using a robotic approach can be an added benefit for the patients, for surgery being less invasive. I would like robotic surgery to become cheaper. That's not a platform thing, but that's I think the major drawback for robotic surgery at this point. But I think, yeah, single port surgery, maybe tactile feedback will be interesting for starting surgeons. The new platforms have tactile feedback, which can be interesting. I don't think it's important for more experienced robotic surgeons, because you get the type of visual feedback which gives you the opportunity, or which makes that your tissue pressure or your strain on tissue isn't too high. But maybe for beginning surgeons, tactile feedback can decrease the learning curve. So I think the issues at hand now are being promising.
No, I think definitely what you say, and also one of the remarks that you hear from open reconstructive surgeons is sometimes that they say, but it's we're dealing with very precise operation with tissue that's fragile, and with the robot it's just too harsh, the force that's being applied. And if we have tactile feedback, first of all, it would be easier in the beginning to understand how to handle the tissue. And indeed, if you've already a lot of experience, then by watching, you have an idea how much pressure you're putting on the tissue. But that would, I think, as well be a major advantage, also from learning perspective.
Yes, thank you. And somebody asked how, if you can address the cost effectiveness and the footprint of the robotic surgery. I think it.
Yes. So of course we all know, I think, that the robot is yeah, for the footprint, that's for the environment, the robot is not the best surgical approach. Yeah, I think you could argue that all technological advances are also technological advances that are there to create solutions for environmental problems and the footprint. I think we can look at it in a positive way. And I think also with all the continence surgery that we do, yeah, we also help people become continent, which means that they definitely, if they're young, that they do not all their life need to wear protection, which is of course also a disaster for the environment. But yeah, it's a question frequently asked, and a right one to ask, I think.
Yeah, I think for now it's safe to say that robotic surgery isn't cost effective, which might improve in the near future as more robotic players are available, or commercially and readily available. So I believe, or I hope, prices will drop. As all technical advancements are expensive at first. So I hope cost effectiveness will improve, and I think also footprint or environmental issues will be addressed. I think the environmental aspect of surgery and of OR functioning is booming the last couple of years, and I think this will also cross over to robotic surgery.
Yeah,
and for the
sounds logical.
You could also say, you've seen it, that the perioperative outcomes are much better. So that means less hospital stay, less complications, which means often less extra costs or less operations. And if we also saw that for some procedures, the functional outcome is much better, meaning that they do not need to have another operation because other problems are already solved. These are also things, when you look at it in large and with the perspective for the future, that can also reduce the costs, making it more cost effective.
Thank you. I can see another question came in. That's actually a question for me. That doesn't actually happen. Yeah, somebody asked if there are participation certificates. That brings to my next point, is that we usually hand out CME points. We get our webinars accredited, so you can fill in the post-webinar survey. That will help us and continuously improve our sessions, but you will also get a certificate if you fill in the post-webinar survey. However, I am not sure if this webinar got accredited yet, as it's submitted right now. So fill it in, and if it gets accredited, then you will receive a CME point accreditation certificate. But we do not send out participation certificates, unfortunately. So that was all from my end. I did not see any other questions come through. We still have 10 minutes. I don't know if you guys have anything else you would like to discuss, any last remarks? Otherwise, we can close the session. That's also fine.
Yeah, we went a bit too fast today.
Yeah.
No extra remarks for me. I'll go for robotic surgery.
Yeah, I think
because I'm a bit too much of a fanboy. So, but
yeah, well, I really much enjoyed your presentations. I think the robotic surgery, at least the videos look very cool, so I would be convinced. So thank you so much for being here and presenting the webinar for us. Thank you for the live attendees who came to the session. Oh, maybe one last question at last. Is there any short courses or fellowship in your center for robotic reconstructions?
we can always see. So we don't have an official robotic fellowship. We do in Antwerp have quite a lot of visitors who come and participate in robotic surgery, either functional or my oncology colleagues also host a lot of visitors. So we can always look at possibilities, but for now we do not have a dedicated fellowship for, let's say, 1 year. That's maybe a thing in the future. But for now we can see, well, can always see what's possible.
Now, for somebody who's interested in learning those things, yeah, OFC, I know they have a functional robotics course of 2 days, which is fully dedicated to functional urology, which is, of course, very interesting. And otherwise, yeah, there are some fellowships, but you can also contact, so the studies that we showed or people from the ICS, you can always contact them and asking whether you can visit them or with us. For myself, I did the same, and I visited two centers in France, and yeah, you can see all the operations they do. Perhaps also interesting, the ICS will soon have a robotics committee. So everybody who's in that committee, you can definitely ask them, yeah, if you can come there, take a look, and often they also have great fellowships.
I will have a look and see if I can mention the links to their websites or something in the description of the YouTube video, which I will be posting tomorrow of this recording of the webinar. So people can maybe click through the links and see if they can apply for anything themselves. I do see that there are 2 other questions that just came in. So what is your preferred bladder derivation procedure?
I don't understand exactly what you're referring to as bladder derivation.
Perhaps bladder deviation procedure, I think.
Maybe rephrase the question and we'll go to the second question first. So the second question was, when performing sacrocolpopexy, do you use absorbable suture or permanent sutures on the vagina? I think I definitely use absorbable sutures on the vagina, which give you the option when you peer through the vaginal mucosa, you just wait and the suture goes away. I think literature is there that absorbable or non-absorbable is as good. I use delayed absorbable PDS sutures on the vagina. But I think there's no need for non-absorbable sutures, as you can only increase your risk of vaginal complications with non-absorbable sutures. Now the promontory, I do use sutures, no tackers, and there I do use non-absorbable sutures. Even there you can discuss promontory maybe. but there I use two non-absorbable Prolene sutures.
For me, the same. I use a Vicryl 2.0 for the sutures in the vagina.
And then the question, okay, so the bladder derivation procedure question was elaborated a bit. So the question was if we prefer Mitrofanov or another type of procedure. I think you're referring to continentomas or continent channels. I think I do like to use the appendix when it's there because you have a lower complication rate. Nevertheless, all channels are prone to complication and prone to repeat surgery. The appendix, being a tube as nature designs it, tends to be, in my opinion, a bit more resistant to problems and complications when compared to other types of channels, which you have to construct yourself, and you have a lot of suture. So yes, I do prefer Mitrofanov. There are some publications which I think are quite interesting in people having a lot of fatty tissue, where there is a very large, a very long trajectory subcutaneously, which has to be surpassed. You see people doing an augment with a vesical segment, as they do an Indiana pouch, but then with the ileocecal segment remaining open and suturing that to the bladder. And then the catheterization, as with the Indiana pouch, goes through the ileal segment, which you can choose the length of the ileal segment, and you aren't that restricted to the length of your appendix. I think that can be a quite interesting suggestion for the larger patient group, which in my hands is a difficult group to treat, nevertheless, but especially with continent channels, can be quite challenging.
The last remark is, I think, a nice one to close off the session with. Somebody says, thank you so much for this webinar. I am even more certain that I want to chase a career in robotics within the field of urology. So I think we reached a good point in this session.
Thank you. Good luck. Yeah.
So I would like to thank you again for being here and presenting, and thank you for the attendees. And yeah, we will be at the EAU, like Michelle mentioned, from tomorrow or the next day. But come by and we can talk more about what EUROGEN has to offer and the webinars. So have a good evening, and I will see you all in the next few days. Bye-bye.
Yeah, bye.